Good evening, everyone. We want to welcome you tonight to Cutting Edge Care, Autologous Biologics for the Modern Primary, Family, and Sports Medicine Practitioner. My name is Rebecca Flagg. I'm a Clinical Education Manager with Apex Biologics, and we have three esteemed physician panelists with us tonight, Dr. Bert Mandelbaum, Dr. Stephen Poon, and Dr. Ariana Demers, who will provide valuable information and conversation that are shown on the agenda that I will display here on the screen. This discussion tonight will be followed by a Q&A session. So to make this as beneficial as possible, please utilize the chat function that is on the bottom of your screen, and feel free to submit questions at any time during the presentation. We would like to welcome Dr. Bert Mandelbaum, a leading orthopedic expert who graduated from Washington University Medical School, completed his residency at the Johns Hopkins Hospital, and now works at the Cedars-Sinai Kerlan-Jobe Institute affiliated with UCLA. Recognized for his research and sports medicine contributions, he served as team physician for UCLA Athletics and the LA Galaxy, and has played vital roles in FIFA World Cups and the Olympic Games. Dr. Stephen K. Poon is a primary care physician specializing in sports medicine at the Mayo Clinic in Arizona. He holds a medical degree from Tufts University School of Medicine and completed his residency in family medicine at Wake Forest University. Dr. Poon further advanced his expertise with a fellowship in primary care sports medicine at the University of Washington. He is a member of the American Academy of Family Physicians and the American Medical Society for Sports Medicine, where he serves as vice chair of the Academic Interest Group and chairperson of the annual Combined Survey Subcommittee. And lastly, Dr. Ariana Demers is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. And at this time, we would like to pass it over to you, Dr. Mandelbaum.
Well, a pleasure to be here, and once again, a pleasure to talk about orthobiologics. And I'm going to share screen here, if I may. So we can call up my slides, and we can go from there. My role in this meeting, and I'm a sports orthopedic surgeon, we have different approaches at different times, but I really want to talk about and focus on, yes, we're talking about PRP basic science, but I want to say that at this point in 2024, we're prepared to not just talk about the basics of PRP, but really to talk about how we're more precision, how we're more personalized, and how conceptually we use orthobiologics to impact the burden of sport and a new concept we call playspan in the athlete. So that's really what we're going to talk tonight. We're going to jump right in, and we're going to have one of our professional players, a 25-year-old soccer player. And as you look closely, and this beautiful big red arrow is pointing at it, we've got some narrowing of that lateral joint space. And again, what we analogize this to is the elevator is already going down, even though this is a professional player, they're playing, they're not limited. But in reality, what's happened here is catabolism of that lateral joint. And so for all of us as clinicians looking at this, this is early osteoarthritis. Now, from the athletic standpoint, osteoarthritis and the descriptions have been around for a long time. And in fact, the very, very first team physician, Claudius Galen, said that athletes overindulge, they live shorter, and guess what? They get arthritis. And he was a surgeon, philosopher, physiologist. He really basically gave us that first concept. Now, football, soccer has been studied even 1,850 years later, and the NIH really attributes the game of soccer to having an odds ratio for osteoarthritis somewhere between 5.1 and 12 times greater And when it comes to the most elite, it's the highest amount of penetration with respect to OA. We also know that players retire. About a third of them retire with a diagnosis of osteoarthritis. And we also know if you follow these retired players anywhere in the world, from Brazil, as this study was done, that they have a decreased quality of life. They have more pain and symptoms associated with osteoarthritis. So, what do we think as sports physicians? We look at athletes like this, and yes, they're the master of their fate, captain of their soul. But guess what? The cartilage is the master of their career and beyond, ending up with situations like this. And there we come as the sports medicine team to really help and understand this. And again, we look at the Messis, we're looking at the male players, but understand that many of our players are just like this in all the communities all over the world. And here she comes, Simone, making the tackle. Her knee gives out just like that, and she's torn her ACL. Plain and simple, a non-contact injury that we're seeing all over soccer fields, all over America, our players, our daughters. This is an endemic problem we're seeing. Why am I talking about this challenge, and how can we provide a solution? Why are we talking about it? Because this is an age group. It's up 26% in the last decade, as the Aspen Institute and our coalition has looked at, 26% up. And what are the consequences of this? Well, we look at ACL injury, as we've seen from this epidemiologic study, have a prevalence of about 40%, whether you treat it surgically or not, irrespective of management. Post-traumatic osteoarthritis within 20 years. So we need to focus on this. Obviously, prevention is a big thing. And let me tell you what's more, that if you look at Simone and you follow her in this study done by Angelico Mendy, another epidemiologic study of 52,000 participants, if you get osteoarthritis less than 40, you have a 1.53x greater chance of dying from cardiovascular disease. And if you get it after, it's 1.43x. So again, the relationships between these injuries, our daughters, these players, mortality as a hazard ratio is really significant. So we have to think about things. Now, what can we do about this? I'm going to bring you to three concepts. One, injury burden. It's the frequency times lost days. And for the game of soccer worldwide, it's about muscle injuries. We're not going to really talk about, but we're going to talk about ACL and osteoarthritis. The second concept is that we have to understand how we're going to manage these things in a longitudinal way. We have to have an adjuvant, precision, and personalized approach to it, because the term precision is how we become more specific and how we enhance our efficacy going forward. And the third concept is the arc of our lives and careers. That play span is increasing up on the y-axis, only to go out on the x-axis over time. The more we can impact this, improve the efficacy, regardless of the athlete in all these careers, we improve their capability of not only the career, but also their life. Here's an example. The oldest player, King Kazu, 56 years old, playing professional soccer in Japan. So again, we're changing the concepts, and we're changing the roles for orthobiologics going forward. So let's look at the concepts of orthobiologics. And in my lifetime, I really learned everything I learned from this guy right here, Ramon Cugat from Barcelona, Spain, who really taught me one day at a meeting. He called me over. I have a great concept about orthobiologics. Are you interested? In 2007, we had a young athlete, Jonathan Bornstein, an MCL sprain, and we used it, and it was amazing. It was miraculous. Even instead of a 6-week injury, it was a 2-week injury, and CBS Evening News did a report on it. And then there was, as we know, Hines Ward at the Super Bowl got PRP. And then obviously, as we've seen from Kobe Bryant, really popularized the use of PRP. And so as you can see, these 17 years, it's really exploded as we go forward. So now we have a family of orthobiologics in addition to PRP, and we have to look at everything in relationship from corticosteroids way down here to WNT pathway inhibitors. At the end of the day, tonight, what we're going to answer is what's the ideal adjuvant combination and when? What precisely we have to do, and how do we understand what OA is in the joint and shift from catabolism to anabolism, and again, avoiding the progression of osteoarthritis, enhancing playspan, and most importantly, enhancing lifespan. So let's look at this osteoarthritis. If you tear your meniscus, you're 15-fold greater likelihood of getting OA and 7-fold greater likelihood of getting a OA and a knee replacement. So in the end of the day, our job is to disease modify, but that's a tough task. So what we want to do is increase the play span by driving that athlete away from the total knee replacement, as well as improving the quality of their life by increasing the efficacy of what we're doing with things like PRP. So let's get to the ABCs. There are 5 things that we have to know about PRP. There's buffy coat versus plasma-based. We also, and we'll speak a lot about the platelet concentration and how specific it must be in terms of efficacy. How about white count, leukocyte rich versus poor, activation versus not with calcium chloride or thrombin, and how do we dose this in relationship to other adjuvants going forward, all of which we must consider as we choose to take that PRP. Now, how does it work? Let's look at this closely. This is from Von Mao. On an agar, we have MSCs here. We got PRP over here. What happens when the MSCs sniff out the PRP, they're summoned. And when they get there, look what they're doing. They're replicating. So PRP summons, and then when they get there, because of PDGF-A plus BB, this derived growth factor stimulates the mobilization and replication of those MSCs. So when people say, I want stem cell, well, MSCs, number one, are called medicinal signaling cells, but they're the stem cells everybody's talking about. But regenerative medicine is really predicated on this interaction, summoning the MSCs, getting them proliferate in this well-orchestrated and biological integrated system that has a very positive effect on cartilage, metabolism, regeneration, the synovium, the meniscus, and the chondrocytes. So it's very complex, but it's well orchestrated to understand. And also understand that PRP is anabolic and an anti-inflammatory. As you've seen, it stimulates cell proliferation, potentiates the SOX9 transcription, and elevates COL2A1 and ACAN expression in a very anabolic way. And again, when we think about catabolism, anabolism, it pushes that over to the anabolic pathways, which ultimately is our goal. Now, let's speak to this precision number of platelets. In this great study, we find that they conclude that PRP with precisely 10 billion platelets is necessary to sustain a very positive chondroprotective effect. So more is better, as you can see over here. More is better. And one of the attractions I've had to the Apex system is we could dial in a concentration between 7-9-fold and get us to almost as precisely 10 billion platelets overall. Now, we've been looking at this very closely in our BARB study, which is a multi-center study between the Mayo Clinic, Cedars, HSS, Northwell, Colorado, Stanford, and Cleveland Clinic. And we've been looking at the differences between responders and non-responders. And let me show you this curve. It basically shows you, as you can see in the responders, there are more platelets, substantiating the same concept, more is better. More platelets, better responders overall. And that's not all. Let's look at the literature. In these studies, when we look at we could see here in red at 1 month, we're looking at VAS pain score 0 to 10. The more high platelets, more green at 3 months, 6 months, and 12 months. better responders. So again, over and over, we learn that the more is better with respect to response for PRP in relationship to osteoarthritis. Now, there's some false actors out there, and this is one of them. Let me show you the secret here of this right here. This article was published in JAMA in 2021. They say the effect of intra-articular PRP versus placebo has no effect. That's their conclusion. But when you look closely, let's look under the hood. They say in their methods, they use this PRP from Regen Lab. And they say, quote it, they don't have the data, but they quote, they say, the company says in reference 17, 1.6 by 5 times greater. Well, we happen to be doing a study with this company, and we could never concentrate the platelets more than 1.4 to 1.6x. Details matter. And what this study should be entitled, whole blood versus placebo, not PRP, because at a level of 1.4 to 1.6, it's not PRP, it's whole blood. So again, even though it's published, when you look under the hood and you look at precisely these details, you understand that these are really essential to see a significant clinical effect. Let's take the next step. We talked about activation with calcium chloride. If you activate, as you see, at platelets at rest versus activate, they stimulate, they dump from the granules the growth factors, and then these systematic reviews shows that activated PRP is more effective at improving pain and functional scores in knee osteoarthritis. Important detail. Adamance has given us this detail. Just having your patients on a stationary bike before they give you their PRP sample, 20% more concentration of PRP. Just riding a bike, doing vigorous exercise. So we have all our patients exercise before and after they give their PRP. How about other details? Now, as we talked about adjuvants, if you take HA and PRP and you mix them together, it induces the release of TGF beta 1 and PDGF. Remember I showed you before the MSCs are attracted? It's all because of PDGF AA and BB going forward. And you see the release of these going forward is greater with the use of HA and PRP synergistically. And when you look at this coming from Rush and Brian Cole, they looked at a systematic review and they conclude that PRP plus HA has a greater improvement than HA alone. And again, now we're getting to the advanced course of thinking about the best ways to treat our patients, just like other areas of medicine. You can't treat heart disease with an antihypertensive without a statin, without another antihypertensive. And what we're doing, we're getting to the level of adjuvant approaches to these issues going forward, improving efficacy. Alberto Gobi from Milan, Italy, has done a prospective randomized clinical trial and compares autologous microfragmented adipose tissue to PRP, and he finds that the adipose tissue is equal to PRP plus HA. There was no significant superiority. So we're looking at techniques that are invasive, that are probably 10 times the expense, and just PRP and HA alone is just as efficacious. Another detail going forward. And if we look at in the sequence, a study coming from João Espargueira Mendes from Porto, Portugal, where they looked at MSCs plus PRP versus MSCs and cortisone. Up here are the green curves. It turned out that culture expanded bone marrow derived MSCs plus PRP was the best overall. So we get to this level that we can't just think about, is it about MSCs? Is it about PRP? Is it about HA? Probably best about these adjuvant multimodal treatments for osteoarthritis. And this is just another example. Well, let's dive a little bit deeper because now we've taken the PRP sample, but we also have the PPP, the one that does not have the platelets, we think, and we're taking it out. What's really another great thing about the Apex concentrator, as you see here, is you could then take out, again, here is the plasma, here's the PRP, and here are the red cells. We're going to take this volume and we're going to use that. And we're going to say, okay, maybe there's something we could mine from there that could help us as well. And Jason Dragoo and I have been looking at this, working at this in Jason's study of looking at how we can what we can concentrate from, again, the PPP using this concentrator. And there's a whole array of things that we can look at. Now, why is this important? Because as Arnie Kaplan has given us the role of the MSC. And again, here we are again. Here is the pericyte that lives on the blood vessel that is stimulated by, guess what? PDGFBB. It lies in there, and we can concentrate that, as you see in this curve, in a very statistical way with the concentrator, which activates these pericytes, again, to come to the party with the platelets and have this very significant anabolic effect. And again, we have to understand these systems. It's very specific, and different mediators, different factors have a different effect. Other thing we can concentrate with this concentrator is interleukin-1 IL-1 receptor antagonist. Again, it is a very potent inflammatory meter, interleukin-1, and this is a receptor antagonist that exists there, as you can see, in a statistical way, as we can concentrate it with a concentrator. And lastly, one of the most interesting macromolecules, alpha-2 macroglobulin, or A2M, at 720 kilodaltons, is something that's really an interesting thing. It's a broad-based protein inhibitor, and it works like a Venus flytrap. Watch it work, just like that. As you can see here, it binds, and it, like a Venus flytrap, it binds these proteases and eliminates a lot of the catabolic aspects of putting it into the bloodstream. But it also, in addition to decreasing the levels of MMPs, TNF alpha, and neutralizes interleukin-1 beta, it increases the expression of the anabolic protective genes, COL1, type 2, SMAD4, and aggrecan, as you can see here. So both sides of the equation at the same time, again, forcing the weight of the curve to the anabolic side, which ultimately is our purpose going forward. And this coupled to this article coming from NYU that showed the effectiveness of A2M alone is good and similar to the effectiveness of PRP. So we're looking at some of these studies and how we compare one to the other, but progress is progress. And where we are today is what we call the trilogy adjuvant cocktail, which is HA, PRP, and A2M all working together. And we have a study ongoing right now looking at how effective we are at limiting progression and improving the anabolic changes going forward. And again, one of the things I want to talk about as we talk about athletes, believe it or not, a little trivia, there were more women athletes that won gold medal for the U.S. than the men. And all these great faces of women athletes, we must focus on their differences that they have. Viva la différence. And some of those differences are that osteoarthritis in women is associated with estrogen deficiency, published 16 years ago in 2009. Why is this? Well, cartilage has different estrogen, anabolic, and progesterone receptors. And they vary. They come in different isoforms, and they vary with menstrual cycle, pregnancy, menopause, ACL tear, and osteoarthritis. So it's very dynamic. And when estrogen is pulled away, the chondrocyte suffers. What's most fascinating, last year, they discovered the relationship of how that occurs. The estradiol, as you can see here and published in this article in 2023, has a direct effect on what we call the SIRT, or the SIRT1 mRNA system. And what it does, it activates the AMPK and mTOR system that affects in a very positive way the viability and proliferation of the chondrocyte. So now we understand the direct relationship between estradiol and the chondrocyte. So at the end of the day, to preserve the chondrocyte, we need estrogen to help these female athletes along. We've got to treat all athletes in all different ways, and understand these specific mechanisms is really important. So how do we conclude here? Well, as we talked about placement, we talked about aging as David Sinclair did, and he gave us the whole concept of epigenetics, of how we could turn on all these pathways by doing all these lists of things. In the end of the day, what we're interested in is play span, keeping our athletes playing a long time, living a long time. And you're hearing a lot about it, whether it be Peter Attia or Dan Buettner or David Sinclair or us talking about play span. In the end of the day, what we want to do is drive up the curve, the efficacy of what we're doing, which drives out the ability to have a longer career and a longer life. And I think that's our goal for each of us by affecting through orthobiologics and epigenetics these pathways. So in conclusion, it's all about precision medicine now. It's the ABCs, but it's the next level, the advanced course. But the devil is in the details. It's about specificity of numbers, use of activators, and understand the triad and how these systems work together. Adjuvant therapies are synergistic to optimize results, and we have to think in those terms. And something that's a very, very contemporary concept is unlocking the platelet poor plasma is one more tool we have in our tool chest. Most importantly, to increase the play span, and most importantly, increase our lifespan. Thank you.
Thank you so much, Dr. Mandelbaum, for that. And to piggyback off of unlocking PPP, we're going to hand it over to Dr. Demers, who has some new and exciting data on protein concentrate. So, Dr. Demers?
Awesome. Thank you so much, Bert. That was great. I just absolutely love that. It's so good. Hopefully you can see my slides, and we'll be talking about unlocking the power of platelet-poor plasma. So let's dive in to protein concentrate. This is what I'm really excited to talk about. As you know, and as we just talked about, the devil is in the details. And so this talk is going to be about the details. And I wanted to share with you some new science that may help us on our quest for treating our patients. Of course, there's been a lot of science through the years about PRP, or platelet-rich plasma. And as we know, one of the waste products of PRP was the platelet-poor plasma. And for years, we've thrown that away. Now, as time goes by, there's some really amazing things that have been discovered about platelet-poor plasma. And there's some new technologies to harness these exciting things and the scientific molecules in the plasma. And so that's what I'm going to share with you today. So this is all about concentrating the plasma, and this is also called a fluid volume reducer or a filter. And these are just filters. Many companies manufacture these fluid reducers, but we do have a new technology at Apex that I wanted to show you the power of, because that's been really enticing to me with this new technology. So one of the devices on the market is what we call the predicate device. So we'll call that the PCP, and then the new Apex fluid volume reducer, we're going to call the PCA. And there's quite a bit of a difference on the pore size of the filter itself. The predicate device is the kilodalton size pores is 65 kilodaltons, whereas the new technologies from Apex is quite a bit smaller at 15 kilodaltons. And really cool things is that we can use these filters to collect these much smaller proteins, these much smaller molecular weight proteins, such as EGF, PDGF, BB, which we just heard from Dr. Mandelbaum, and then, of course, A2M. So I wanted to go ahead and just talk a little bit about this study and the design of the study and what we did to look at this. So this study was 120 cc blood draw from 12 donors, and we then used 60 cc's testing the comparator or predicate device, and 60 cc's testing the Apex fluid volume reducer. And then what we wanted to look at was whole blood, PRP, PPP, as well as the wastewater collection after concentration to determine how efficient this filter actually was. And were we leaving some of these proteins in the wastewater? So that's what we started to look at. So obviously, this is where we start to look at the test, and we're going to be showing the blood as well as that centrifugation, and PRP was removed from both samples, and it was approximately 30 mLs of PPP that was processed. But then we get, so this was all processed in the very same way, but then at the end of the day, we get very different results from the two filters. And so you can see that the Apex technology removes significantly more water. Then you have a significantly more viscous concentrate, 4 ml concentrate, and instead of that 7 to 9 ml non-viscous concentrate from the predicate. And while there is a little difference in the platelet for concentrate, we were able to still harvest the remaining platelets that were in the platelet poor plasma, which is really interesting, that we can then data mine or reharvest those platelets that were previously we were just throwing away. We're getting rid of the platelet poor plasma. So what we did when we looked at that, because we were able to trap those platelets, and both devices were able to trap the platelets, and so there are a similar number of platelets, but you have to remember it's in double the volume in the predicate device versus in the new Apex device. So while we are, it's in a smaller volume that we'll be able to concentrate this remaining platelets that we're being able to capture from the PPP. And because we can use a smaller volume, this is more viable when we're looking at clinical applications. So here we are. This is the roadmap of the science project that we did here, and what we are interested in, and some of these biologic molecules that we're going to talk about. So we'll go over and kind of go over what this filter can do, and can we collect these biologically active molecules. So this is by mass, these molecules. At the top of the chart is the A2M. A2M is a huge molecule. And so as we just spoke about with Dr. Mandelbaum, it traps very harmful enzymes and proteases. And so this is very different than the much smaller proteins that we have at the bottom of the chart down here. So, you know, the A2M is 720 kilodaltons, whereas IL-1RA is, 22 to 25 kilodaltons. And so it's really interesting that we can start to trap some of these proteins. And if you look, there is a difference. So both of the filters are able to trap the A2M. But when we start to talk about the filter pore size being much smaller at 15 kilodaltons, we then can start to collect these other proteins, such as IL-1RA, TNF receptor, PDGFBB. And we're going to go into this. So this is just that A2M macroglobulin, and obviously that's that cartoon, and it's a really potent protease inhibitor and controls that anti-inflammatory role with the controlling the inflammatory environment, both from the anabolic and catabolic side. So with the A2M, when we compare our two filters, this should be a chip chop for all the filters because it's such a large molecule. And what we found is that we could concentrate A2M because A2M is in the serum. So we can actually concentrate that significantly higher level from the serum, the platelet poor plasma, rather than the platelet rich plasma. As you can see, it's in the serum that we're finding this A2M, and we can concentrate it at 5 times concentration as compared to platelet rich plasma. And we were able to concentrate it 1.1 times higher with the apex versus predicate, but that's what we would expect because it's such a large molecule. Of course, we're going to be able to capture that in either filter. And really, we do want to draw your attention to the fact that alpha-2 macroglobulin is in that serum, and by taking the platelet poor plasma and concentrating, we're actually able to concentrate this at a much higher level for a nice anti-inflammatory option. But this is just the beginning because this doesn't end. The story doesn't end here. So as we get down to the nitty gritty, we'll talk to the IL-1 RA. So that's the receptor antagonist. As you know, IL-1 is an inflammation protein, and the IL-1RA is a potent anti-inflammatory mediator. So this neutralizes that IL-1 effect. And when you have the IL-1 receptor antagonist, then that activation is blocked, as you can see in the cartoon, and that it blocks that inflammatory cascade if the IL-1 RA comes into that receptor complex. So this is really very interesting, and it's really important to know that we can now be able to concentrate IL-1 RA at that 24 kilodalton level to be able to neutralize a very, very potent inflammatory mediator of IL-1. So we do know from this study that there is a minimum ratio of IL-1 RA to IL-1 of 100 to 1 to have a clinical effect. And so what's really exciting is when we look at our data, we were able to perform at a significantly better ratio because of that small pore size. We were able to collect that IL-1 RA at a much higher level with that ratio of 100 to 1. And so when we're able to have that ratio appropriately, we get this great effect. So looking at the other filters, we weren't able to perform as well with the concentration of the filter with the larger pore size. So there are other ways to use and concentrate the IL-1 RA, but ultimately that is not currently an option in the United States. And so for the clinicians that are looking for this IL-1 RA option, this becomes a very interesting option to have the appropriate ratio of 100 to 1 to be able to have a clinically significant anti-inflammatory effect. So next, we have now alpha-2 macroglobulin as well as IL-1 RA. So this does not stop. The next one on the list is this soluble TNF receptor. So TNF, or tumor necrosis factor, is a very powerful inflammatory cytokine. And this is close to, similar to that IL-1, which is a significant inflammatory cytokine as well. And there is a lot of similarities. However, TNF and its cascade is much more complicated because it's controlled by soluble receptors. So if you look at this cartoon, there are receptors for TNF on the cell surface, but there's also soluble receptors that are floating around in the serum or the plasma. And then these TNF alpha can then be locked into the soluble fragments and then inactivate the effect of the TNF. So it's this counterbalance of the body to naturally make sure that these molecules aren't too concentrated. In the same way, we can then concentrate these soluble receptors in comparison to the TNF. So we need a high soluble TNF receptor to TNF ratio. And we were able to make sure and get that done. Obviously, these are serum-based proteins, and because we didn't see them in the PRP, if you look at the graph, this is low in PRP, higher concentration in the predicate as well as the Apex PC device, but significantly higher in the Apex PC device because we're able to have that small pore size. And if you look, this is statistically significant, which is quite exciting. But are we done? No, we are not done. Because right around this 25 kilodalton level, we also have something else really important, this platelet-derived growth factor, BB. And like Dr. Mandelbaum was talking about, this is a really important platelet-derived growth factor, BB fraction, that is responsible for releasing these pericytes from the vasculature. These are around the blood vessels, and they're in the same working family of the MSC, or the medicinal signaling cells, and they're released from their perivascular space to be able to start to be activated and be useful in clinical medicine. So the reason I'm so excited about this is because now you have the opportunity to be able to say, okay, great, I would like to use a plasma or blood-based treatment, but I also want to activate the local MSC niche. And you can start to use the plasma concentrate with the concentrated PDGF BB to stimulate and activate the local MSC niche around the area where you're working. So the PDGF BB is captured in PRP for the most part, but ultimately so that makes sense. But ultimately, as you see on this graph, but when we compare the PPP alone to the concentrated platelet poor plasma, we are able to go ahead and concentrate these to a much higher level. So clearly the next step where we would like to get to is looking and saying, okay, very similar to IL-1RA, and we're going to be testing this in the PDGF fractions, is how much can we concentrate this PDGF-BB in platelet-rich plasma, and can we concentrate our PRP to have local benefit in our soft tissues and joints, stimulating our MSC niche to activate with that PDGF-BB at a higher concentration. Are we done yet? No, we are not. So here's the EGF, or epidermal growth factor. It's quite a small protein. It's only a 6 kilodalton protein that stimulates cell growth. And what we were able to do with our filter is be able to concentrate it. So it's a 2.3-fold concentration with our Apex filter, which is really exciting. And, some specialties are more interested in this, such as burn or, wound care, where we are really looking for skin-based therapies. But clearly, what helps us understand is this filter has really excellent performance, even to the 6 kilodalton level. So this was quite exciting finding. It was unexpected and beneficial for sure. So the last part is this wastewater, the examination of the waste products after you filter it out. And we want to make sure that we are not leaving things in the wastewater. And so the things that we were really trying to keep in our super concentrated plasma is the soluble TNF receptors, as well as the IL-1RA. And we don't want it to be in the wastewater that we're then going to throw away. And so when you look at these graphs in the Apex PC, the soluble TNF receptor concentration is 0. It's just not there. And so we're really happy that there's nothing in the that we're not losing that soluble TNF in the wastewater. And then if we look at the IL-1RA, we wanted just to make sure that what we're having is our concentration, and it's quite low. Please note this is in picograms. So this is quite exciting that we're not losing those IL-1RA fragments for the most part in our water. It's really quite low, which is exciting as well. So as a summary, this is a lot of science. Just dropped a big science bomb on you, but I wanted to just kind of summarize what we've talked about. So in that second column, with the Apex concentration, you just kind of have a line by line comparison. So this is per ml. So obviously the platelets are double that concentration, as we know. We didn't find more platelets. We just we concentrated it more efficiently. And then we're able to make sure that that PDGF-BB is a significantly higher fold concentration. That A2M is approximately the same, maybe a little bit more. But then we have the IL-1RA as well as soluble TNF and EGF, which is quite exciting and really nice from a fold concentration comparator. We're quite excited to be able to capture all these really biologically active molecules to help drive our reparative process, as well as a potent anti-inflammatory and immune modulator way to be able to take care of our patients. So really exciting stuff. What we used to throw away, now we have the ability to it's becoming front and center. And we're going to be talking more in the future about other applications for this product, such as treatment for muscle injury, as another thing that we're really looking at for a nice, highly anti-inflammatory preparation, as well as those patients that may have failed or had a really large flare with your orthobiologic treatments. You can then consider maybe a PC or plasma concentrate option to still get those cytokines wrapped up, but also some platelets and some stimulation of the PDGF-BB. So I wanted to thank you so much for joining this big science bomb tonight, and then we have some new exciting things happening with Dr. Poon. So thank you so much for your attention.
All right. Thank you, Dr. Demers, and thank you, Dr. Mandelbaum. Just an honor to be here with you all, and appreciate everybody here. So my talk is a little bit of a pivot to more of some of the clinical aspects in terms of a day-to-day application. So, what do I do as a primary care sports medicine physician? I always say that there's a lot of different hats that we wear, a lot of different names. You could see it under primary care sports medicine, non-surgical sports medicine, exercise and sports medicine, interventional musculoskeletal specialist, and so on. But my particular background, I always say, despite all these hats, my passion is in sports medicine, but my heart always lies in family medicine. So, there's my primary residency training in family medicine, fellowship in primary care and sports medicine, and dual board certified. And so, what are some of these different hats that we wear as part of this? So, providing comprehensive care for athletic and non-athletic populations, including the management of their injuries. They could be acute injuries or overuse. Also, some of the acute and chronic illnesses related to athletes that they might sustain, even in a non-musculoskeletal realm. So, in the primary care world, especially if there's some family physicians joining us tonight, is osteoarthritis extremely common: knees, hips, shoulders. I think Dr. Mandelbaum did a really great summary of some of the literature that's out there. It's just expansive. The amount of literature that's really been published, high quality literature, especially over the last 5 to 10 years, is just an incredible amount, ever expanding and showing the utility for different treatments of symptomatic osteoarthritis, including the regenerative realm. Well, another very common issue that we'll see in primary care is lateral epicondylosis, commonly referred to as tennis elbow. For those of us who see it frequently and manage it frequently, we understand that it can be very chronic and degenerative in nature and not always inflammatory. And, this isn't necessarily new information. So this study back in 2001, comparing different treatments for tennis elbow, looked at comparing injection therapy with corticosteroid versus control, which is no injection or no intervention at all. And directing your attention to the graph in the middle right, you could see that at baseline, both were relatively the same in terms of pain with sport. 4 weeks after, the black box highlights the injection, the pain would decrease. But then by 8 weeks and beyond, you could see that the pain with sport certainly returned. And if you could see with VAS and other metrics, pain after a corticosteroid injection was often about the same, if not worse symptomatically, over time compared to just control and not doing injections at all. In 2006, we could also see that comparing corticosteroid injections, waiting and watching, or physical therapy, looking at how those changed in terms of play in their sport with unaffected pain with grip. And you look at 3 weeks, the blue dash line would show that the corticosteroid injection showed some great improvement over the other modalities. That held true at 6 weeks, but when you get to 3 months and 6 months, the corticosteroid actually performed worse than doing nothing at all and doing physical therapy. So this study was a systematic review looking at corticosteroid injections, PRP, and autologous blood, which is essentially just whole blood in the treatment of lateral epicondylitis. And they looked at pooled responses comparing these different treatments, right? So the red would be the PRP, the blue, it would be the autologous whole blood, and then the yellow would be the corticosteroid. So when you look at the time break where they separated as less than 2 months after the intervention and greater than 2 months after the intervention, you could see that the PRP, by and large, performed better than the corticosteroid as the time went on. So we could see that the corticosteroid, as it's been shown over and over again, would have some immediate effects, maybe in the short term, but in the long term, certainly underperformed doing nothing at all. And then when they compared it head to head with platelet-rich plasma, again, we're seeing some of the use of these biologics in very common musculoskeletal conditions that would last much longer. So lateral epicondylitis, it goes beyond just the pure musculoskeletal element of it, right? So again, my heart and family medicine, right? So these studies out there are seeking to associate these particular conditions with different common primary care issues. So relationship between lateral epicondylitis and total cholesterol levels, an increased incidence of lateral epicondylitis and tobacco use, And then even a large meta-analysis of risk factors for lateral epicondylitis. And what did it show, right? That more common in females, more common in those with a smoking history, manual laborers, high cholesterol, and even the potential for statin therapy. So we know that certain medicines, antibiotics, fluoroquinolones can increase your risk of chronic tendinopathies, but there's even some suggestions that statin medicines, vital and necessary as they are, can also be associated with this. So in some instances, in the best ways to treat patients for their cholesterol, primary prevention, secondary prevention to reduce risks of heart attacks, strokes, and others, we may be unintentionally causing some other issues as well. So that's one hat I wear. And then another hat that I think about is also in the treatment of high-level athletes. So I could say that as proud as I am of what I do, I can't really hold a candle to Dr. Mandelbaum's world travels and experience with USA Soccer. But, these are all some of the factors that we consider when we're treating our athletes, right? What is the sport that they play? What's their competition season? What are their training demands? But also, what are the common injury patterns? Dr. Mandelbaum highlighted ACL injuries. Again, each sport has certain acute and overuse injuries that may be common. And then also factoring the athletes. What's their recovery time frame? And when we decide on treatments, we also have to factor in what their regulatory bodies are. That could be different depending on if they're high school athletes, collegiate athletes, professional athletes, or international Olympic level athletes. So again, if you are seeing primary care and musculoskeletal issues, you might have some people come into your office. You might have this guy come in and says he's got some blood pressure issues that he needs to manage. She might have some seasonal allergies that flare up for 3 or 4 months in a row. And he might have some acne, right? So what are some common things that we would use if you yourself were going to see a primary care physician or you're treating a patient that might come in? So you might think about some pseudoephedrine for viral or allergic rhinitis. For hypertension, it's common for some patients to use beta blockers for different conditions. Acne, you might use some spironolactone as a management treatment, and you might see a lot of patients in teenagers and adolescents on that. And for seasonal allergies, sometimes clinics will give intermuscular Kenalog or glucocorticoids for this. But when we think about those populations that we're talking about, these high-level athletes, these regulatory bodies ultimately all fall under the World Anti-Doping Agency. So beta blockers, as common as it is for some patients with atrial fibrillation or hypertension, it's banned in shooting sports because it can help with intention tremors, and that gives an unfair advantage. So we have to factor that in when we're treating them. When it comes to spironolactone, it's a diuretic, commonly used, again, for acne and sometimes for blood pressure, but it can be used as a masking agent to hide some other banned substances, so that's prohibited at all times. And then glucocorticoids. So again, kind of a mainstay of musculoskeletal treatment for years and years. And up until recently, the World Anti-Doping Agency had considered it banned at all times. Now it's prohibited in competition, but there's still plenty of athletes that understand that the responsibility for their competition, their eligibility, falls onto them, and they know that they sign notices knowing that anything that they put into their body is ultimately their responsibility. So sometimes they don't want to take the risks with washout periods and appropriate timeframes for doing intra-articular or intratendinous injections for their various pathologies. But what does WADA comment about PRP? So PRP is allowed, it is not prohibited, but it's also important to note that you don't want to isolate individual cytokines to provide a therapeutic effect. When it's used in combination in a preparation such as PRP, it is not prohibited. But sometimes when you start to scale out, if you were to just isolate and grow an individual cytokine, that's where it might fall into some issues. So then we pivot again, right? So again, back to a very common cases that you might see in primary care, and then just kind of a visualization of how we might utilize some of these orthobiologics. I know there was a couple of questions earlier on, and actually this section touches on some of that information that we'll answer. So this is a patient that I saw. He's in my practice. He's a 49-year-old male with bilateral knee pain. And I think we've all seen this, whether we're in primary care or in orthopedics practices. His weight is 183 kilograms, 404 pounds, BMI of 57.8. So I want to pause right there, and just even me saying that, just, we think about, what do we think about this individual, right? What's the association that you have with this individual just coming to your mind just with that, right? And just let's hold that thought. I want you to partake in this exercise for me. So his background is that he worked as a landscaper. He was active every day, but he relocated from a different state into ours. His wife got a new job, followed her, and he moved to a desk job. He was more sedentary. He was more depressed. He ate more, and his weight kept going up and up. And so over time, he had received corticosteroid injections for years, but his effect had been waning with shorter and shorter duration. So he told me that at most, he had about 3 months of benefit from any type of corticosteroid injection. But since then, it had been years since he'd received anything, but his knees continued to hurt, and he knew his weight was going up. So these are his x-rays. You can see with bilateral views and the AP views, he's got some medial compartment narrowing, maybe just the tiniest bit of some bone spur development, but otherwise relatively well-preserved joint space. He's got a benign enchondroma in the left knee. His MRI of his right knee showed a lateral compartment chondromalacia. The medial compartment also has some chondromalacia, a little bit of an extruded degenerative meniscus, and it was similar on his other knee. So again, relatively benign, all things considered, given his duration of pain, his body weight, and so on. So a summary of some of the treatment that he'd had. Back in September of 2022, he had some viscose supplementation injections. The thought at that time was that he had such continued exposure to corticosteroids that maybe that repeated dosage may be harmful to him, so seeking other treatments. So he had this single injection viscose supplementation. Unfortunately, had about 1 day of relief before a sudden exacerbation of pain, which lasted for about 3 days. And this was attributed to a pseudoseptic reaction, which would be common and a commonly reported side effect with this particular product. A few months later, because of the pain increasing, he wanted to try another corticosteroid injection. So this was the first one in about 5 years. And at that point, again, he had estimated well over 10 injections in his lifetime to both of his knees. So also at this time, he had sought out some other treatment options, and he was not a candidate for surgery given his BMI. So how did he respond to that? He came back in April 2023 for a repeat corticosteroid injection. So he had about 2 months of benefit with his prior injection. So he tried to wait it out as long as he could, just knowing what we had talked about. But he just, continued to have pain. So what did he feel after that? About 1 month of relief. So unfortunately, again, continuing to diminish returns. So back in June of 2023, I brought him back into the office and said, let's comprehensively review your treatment plan, your history, and your options. So what do we go through about his personal history, right? So again, this is where I want you to think about, what your image of this individual was. So he came to me from another provider who, he sought treatment for his knees and commented on his weight, which probably understandable. And he noted this, right? And so his response to that was very self-deprecating, and he gave me permission to say, to share his words. He told me, and I'll never forget this, that basically, doc, they told me I was too fat. He said, I know I'm too fat, but they didn't have to be rude, and it doesn't mean I haven't tried, right? Because he had invested a lot into trying, but the pain was too much and the weight kept going up, right? So going through the rest of his health history, his peak weight was 414 pounds. So, a few months after I initially saw him, his weight kept going up. He tried exercise, but his knee and his back were hurting too much, right? He tried GLP-1 receptor agonists with semaglutide, but he couldn't tolerate the side effects. And if you look at his initial labs when I first saw him, around the first time I saw him, his total cholesterol was about 191, LDL was 133, HDL was 38, and his hemoglobin A1C was 5.7. So for those who see these labs all the time, not necessarily perfect, but also not bad by any stretch of the imagination, and certainly maybe not what you would expect with somebody who weighs over 400 pounds, right? So 1 year later, again, he rechecked. His total cholesterol was 119, his LDL was 63, and his HDL was 36, and his hemoglobin A1C was 5.5. So again, these numbers were a lot better, and certainly did not show that this was an unhealthy individual with other aspects of his life other than his weight. His blood pressure was 118/74 on a single agent, right? So After we reviewed all this, obviously his motivation was there, but financially he was constrained, right? So that's why we had opted for the corticosteroid injections. That's why we had opted for the viscose supplementation. So at that point, we decided to proceed with a combination therapy of PRP and a 3-shot visco supplementation series to avoid kind of the single shot one where you had the pseudoseptic reaction. So, as we're aware, the FDA still considers platelet-rich plasma as an experimental treatment, so it's not covered by most insurances. I'm fortunate enough to have an office that's dedicated to getting prior authorizations for visco supplementation. So we had that, and it was authorized by his insurance. So we can do both simultaneously. So our treatment plan was week 1, we did the bilateral visco supplementation injections. Week 2, we did the bilateral visco supplementation injection in the left knee PRP. So how we did this mechanically is that we would inject the visco supplement first and then follow that with the PRP, switching out the needle. So through the same needle, but separate syringes, we would not combine them together into one agent. And then week 3, we did the same thing with the bilateral visco injection and his right knee PRP. So I'll skip that there. So looking at some of his numbers, right? So his left knee, his baseline platelets, you can see there, his PRP platelet concentration was about 1.3 million per microliter. And so concentration factor of 7.72. His total PRP volume was 6 milliliters. So his total platelet dose was 7.7 billion. And you can see that the lymphocytes increased, monocytes increased, but the granulocytes decreased. His right knee had very similar numbers, baseline about 166,000. His PRP platelet concentration was 1.6 million and a 10 times concentration factor. His total PRP volume was 5.5 milliliters, but his total platelet dose, given the higher concentration, was 9.2 billion. So again, same patterns as well of increased lymphocytes and monocytes, but decreased granulocytes. So how did he do? Right? He told me that this is the longest treatment duration he's ever had, right? His weight at initial visit, as I discussed, was 404 pounds. His peak was 414 pounds. This was about 7 months ago that we saw him and did this, or actually, sorry, excuse me, a year ago. And so he followed his up with his PCP about 3 months ago. His weight was down to 330 pounds, right? His knee pain was under control. He was able to exercise, and he's just so much happier with his life. His back still hurts because of other issues there, but his knees are at a point where he's able to exercise every day. Again, the motivation was there. He just physically wasn't able to do it. So in preparation for this, I gave him a call and I asked him what his weight is currently. He's down to 275 pounds, right? So again, he's making such tremendous strides in his life. Again, we talked about how unfortunately the PRP was a financial burden for him, but he was, after we discussed this, gone through his treatment history, and he was willing to make that investment into his health, and he could not be happier. So he's coming to see me probably in another month and a half, and we're going to repeat this because he wants to just stay on top of his treatment. So the summary of what we see, right? The primary care, we see challenges every day. We understand that there's a lot of different hats that we have to play in a primary care setting. And not all patients are ideal candidates for these different treatments that we have, right? But we can support them, right? Don't dismiss your patients just because they have these medical challenges. And PRP can play a role, especially in a case like this where they've exhausted other common treatments that have been standard of care for years. But again, cost, while a factor, could also be beneficial as well. So some of my references here.
That was fantastic. Thanks so much, Dr. Poon. That was wonderful. What a great story and what a great application of platelet-rich plasma. When nothing else has been effective, for him to have a life-changing experience with, simple injection-based therapies. I do see a couple of questions in the chat, and I think a lot of them are related to this hyaluronic acid and PRP. I think, you know, the question is, are you doing HA and PRP at the same time or separated? I think you're really clear on that. And then there was a question about injecting autologous PRP and HA simultaneously not being approved by the FDA. And I think you were really clear, but could you clarify just a little bit more clear, more clarification from that, that you feel confident and comfortable doing HA and then, you know, in the same setting, but not the same syringe, not mixing it, and how this is really FDA compliant.
Yeah, so I think there's two separate umbrellas right there because the HA is approved by the FDA for use in knee osteoarthritis. And again, this was also, as I mentioned, we had authorized this through his insurance prior to that injection. The PRP falls under the minimally manipulated same day procedure exceptions that were allowed as physicians for this. So we are not combining them. I would 100% agree that combining HA plus the PRP in the same syringe probably crosses off into probably the dangerous territory where you are creating a different mixed agent in a compounded form. But I think separate administration, you know, it is still within those regulatory umbrellas in the same way that you might put some ropivacaine after doing your hyaluronic acid in there because they're in two separate syringes. So.
Right. Yeah, absolutely. And then there was one final question. Do you have to wait the 6 months to repeat HA and PRP?
Yeah, really good question, and I think it's a little bit longer answer because I get this all the time. So from the HA standpoint, if it's, you know, the insurance interval is minimum of 6 months. That's what we're fairly familiar with from the insurance standpoint. The PRP, there's not a lot of compelling data to say single injection versus multiple injections because we know that there's multiple studies that cite a single injection can last 1-2 years or beyond, right? With that. I think where we are starting to nuance is where there are some studies that suggested that multiple injections, whether it was 2 weeks, 1 week, 2 weeks apart, or 4 weeks apart, had greater benefit than a single injection, may be related to more the platelet dosing and exposure that Dr. Mandelbaum had referenced. I think if you go back and look at some of the kits that had low single dose platelet exposure in the PRP, those did not perform very well. But then when you added them up cumulatively over a span of a month or so, right, the cumulative platelet exposure, you know, over time seems to have done that. So when patients ask me, I often say single injection. It's sometimes, again, they ask about whether 6 months to repeat that protocol, the HA and the PRP. But again, I give them this data and we make the best decision for them at that moment in time financially and whatnot based on the available evidence that we have. But I always tell them that most evidence supports a single injection can last 1 or 2 years or longer.
Yep. Me too. Great job. Yeah, that absolutely. I am currently doing single injection and that the 10 billion number was a single injection for chondroprotective effects of PRP. That was so I think if you're having high concentration, then you're able to affect that chondroprotective effect of a single injection. Awesome. So I do want to be respectful of everybody's time. We did have any last questions. I'd love to be able to help with any other questions. If there's some questions about business, I do have just a quick discussion about pricing, but so raise your hand if you have any questions or pop the questions in the chat. Otherwise, we'll go ahead and make sure that is taken care of. If there's nothing else, I did want to please let everybody know this is so exciting. We are having advanced technology labs in Clearwater, Florida. These are upcoming events for Apex customers. And so if you are interested in doing some hands-on learning, for lipoaspirate training, bone marrow concentrate harvest training, PRP dosing and processing, as well as plasma concentrate or protein concentrate creation and usage, please come. Clearwater, Florida. Why would you not come and come join us? These are the dates. So we'll be doing this the first weekend of every month. And please just RSVP prior to. And if you want to click, if you're like, oh my gosh, this is amazing, I was just looking for this, you can go ahead and scan that QR code and go ahead and register. And then we will see you in Clearwater. Steve and Dr. Poon, any other last thoughts or, things that you've been wondering about or thinking about, things that you're loving to work on currently?
Yeah, so I think there's also another question about the PRP being pro-inflammatory and protein concentrate being more anti-inflammatory. Is there concern with injecting them intra-articularly into the same joint at the same time? So actually, I've been utilizing the PC pretty robustly over the last 6 months and starting to track some patient-reported outcome scores and measures for that. So really good question, and I think it's probably behooves us to have a longer discussion about it than what we have available. But I break it down in short that inflammation isn't a linear cascade. I think it's multiple different signaling mechanisms that are happening within the body. And so we are technically activating inflammation. So that's the pro-inflammatory component of it. That's why some patients will feel some of the soreness, whether intra-articular or intratendinous. But the protein concentrate, again, some of these cytokines are all activating signaling mechanisms themselves. So in the same way that these processes take months to fully heal, right? And so just like if you have somebody with sutures, that's the example I always give. The sutures will come out after a week from the laceration repair, but the skin and wound healing can take weeks to months beyond that to fully complete. So a really good question about that. I think ultimately, though, it's that it is utilizing these signaling mechanisms from inflammation to have these different effects. So again, I think it's just the shortest way I can answer a very, very long answer form.
And I will put something in there as well, because if you're looking at having A2M, A2M is binding up the harmful proteases that you're really not looking for, especially in the intra-articular space. And so for me, I use the protein concentrate in my intra-articular injections along with the platelet-rich plasma. Whereas if I'm looking for an application where I may want some of those proteases, like rotator cuff, I'm holding off on using the protein concentrate application intratendinous for those applications, but using it in the joint to get rid of or bind up those harmful proteases to protect the cartilage.
Well, thank you all so much for your time today and for your insight. And if anyone has any questions, you can definitely feel free to reach out to myself. I did see a raised hand, so if you can take a screenshot of my email, shoot me an email, I'd be happy to answer any questions. If anyone also is interested in scheduling a patient demonstration with a member of our clinical education team, you can send me also an email and we'd be happy to schedule something in your office. But thank you all again for your time this evening, and especially thank you to our panelists. We are so thankful to have you with us and for all of your insight and for answering our questions tonight. So thank you so much, and everyone have a wonderful evening.
Thank you so much. Have a great evening.